David, thank you for that excellent presentation. That was action-packed and really comprehensive. Just getting your kind of overviews of the landscape, and I think you hit across a lot of themes there, which are hitting home for us in terms of that consistency and harmonization of the ethics review system, whilst trying to on balance optimize resources. I should also say congratulations on your Irish citizenship, and what we might do is take up your offer of being involved, and you might be our first advisory person for the national office going forward. So you're going to be staying for our panel discussion, yes. And we can build in some of the discussions around that. So to help us explore these topics further, I'm now delighted to introduce the chair of the session, Dr Mairéad O'Driscoll. Mairéad is the Chief Executive Officer of the Health Research Board, and Mairéad was appointed there in 2020. An annual investment of 45 million in health research activity, and an awards portfolio of approximately 2 million, and leads a staff of over 90 people. So and I must say, just personally, Mairéad has been truly supportive of all the work of the National Office and the committee members. And I think, having the unit embedded within the HRB really enables us to do the work that we want to set out to do. And it also complements, I suppose, the clinical trials portfolio within the Health Research Board as well. So Mairéad, I'll hand over to you so you can facilitate our panel discussion. Thank you.
Well, thank you very much, Emily, and I'm absolutely delighted to be joining you this morning. It's been actually really interesting and really interesting sessions, and as always, you learn so much at these events. So as you mentioned, the HRB took the job on of hosting the National Office. It's about 3 years ago now, but it's been absolutely fantastic to see and to follow the journey, to see how far the ethics committees, the NRECs, have come along the road in that time. And I suppose just generally to kind of follow the whole evolution of the research ethics system here in Ireland. So I think it's all been very positive. Now, as Emily said, there are a load of issues that we could be discussing here, very complex, very important issues in health research ethics. But we only have 40 minutes, so we're going to get on with it. And without further ado, I'm going to introduce our eminent panelists, as they say. So, of course, in addition to David Archard, who is joining us now. David, thank you so much for that really good, excellent keynote. It was wonderful. David is joining the panel, which is great. But we're also joined today by Professor Mary Horgan. Mary is the president of the Royal College of Physicians of Ireland and also chairs the COVID-19 REC. Orla Lane is an economist, but also importantly a patient, public and carer representative on the NREC for medical devices. We're joined by Professor Alistair Nichol, who's a consultant anaesthetist and intensivist at St. Vincent's Hospital here in Dublin, and chairperson of one of the two NRECs for clinical trials. And finally, we have Professor Barry O'Sullivan, who's Professor of Artificial Intelligence at University College Cork. And Barry chairs the NREC for medical devices. So you're all very welcome, and thank you very much for joining us today on the panel. So I'm going to start off, and I'm going to kick off with, I suppose, a general kind of a question for the locals. We'll give David a little bit of a chance now to draw his breath. But can I just ask the panelists, given that the NRECs have now been in situ, I think since about, they have been in situ since May 2021, and can I ask each of you why you took on the role of being an NREC member and what it means for you? And Orla, could I start maybe with you?
Sure, thanks, Mairéad. As you said in the introduction, I've been a member of the NREC-MD committee since it was established 18 months ago. My motivation, I suppose, to join the committee really reflected my long-standing personal experience with the health system in Ireland. So I've been a type 1 diabetic for nearly 40 years. And I've, in that period, I've experienced, the dramatic improvement in medical devices that diabetics use to manage their care. And that has really been transformative. In addition, and more recently, I've been unfortunate enough to have been diagnosed with 2 separate cancers, with a time period of only 3 years apart between both of those diagnoses. Now, one of the striking features actually of being a cancer patient the second time was the innovation that had taken place in medication, in surgical and radiation techniques, and indeed also in the medical devices from the time of the first diagnosis. And remember, it was only a 3-year gap between those two diagnoses. So really it was based on my personal experience, because I've been able to benefit from health research innovation, and I saw the opportunity came up to take part in NREC, and so I decided to go for it, and here I am.
Great, and that lived experience is actually essential. It's so important to have that embedded all the way in from the very beginning. And Mary, how about you? You joined the COVID, but probably you're strong-armed into it, I'd imagine, the COVID committee when the emergency hit.
Yeah, so we started Ireland's first NREC in April 2020, and I think it was an easy answer to say yes at the time. It was a very challenging time for us healthcare professionals, but also for the country. We knew the socioeconomic implications of what was happening. So it was easy to say yes, even though challenging because everything was done remotely. I felt it was really important that we as a country contributed to the global knowledge and our own country's knowledge of how really to get where we are today to a much better place. And that had to be by scientifically robust, data-driven information, and really acknowledging the Department of Health and you in the HRB and Teresa McGuire for really getting it up and running really, really quickly. And it was also an opportunity for me to learn. I mean, I really interacted well with people from different backgrounds, law, ethics, our public representation. So it was a learning experience for me also, and gave me really good insight into various aspects of the really important ethics that surrounds doing any trials.
Thanks very much, Mary. And Alistair, how about you? I'm sure you've enough on your plate every day, apart from joining NRECs, but you very gamely step forward to chair a committee.
Yeah, no. I was very keen to help, for a number of reasons. I've been serving on our local Vincent's REC for 10 years, and like as a trialist and somebody who is keen to bring trials to Ireland and to conduct trials in Ireland, I saw the NRECs and the new EU regulation as a real opportunity in Ireland. And maybe to pick up on what Orla said, cancer in many ways has led a revolution in research through precision medicine, allowing new treatments, but also with the goal of actually increasing access to trials as a very positive thing for Irish patients. So I thought the NREC and the regulation offered a real opportunity to that. And then, as Mary said before, I think COVID really, while it was terrible and had a devastating impact on the health system, patients and their families, the system worked in lockstep. And there were some things that came out of it very positive. And I think the huge COVID trial benefits we saw in Ireland and the results translated to the patients have been an impetus and a new way to do business. So as you said, I'm a busy bunny. I had enough on my plate, but I thought this was a huge opportunity to offer new innovative trials to Irish patients that was too good to miss.
Thanks, Alistair. How about you, Barry? Why did you join? You're chairing the medical devices NREC.
Yeah, I'm chairing the chair for medical devices. I guess my background is very different from Alistair's and Mary's, obviously, so I'm not a medic in any way. So I thought it was just a great opportunity to contribute at a national level, given that I had already been doing a lot of work at a European level on AI regulation and the ethics of AI and these types of things. And I thought that that background might be helpful and useful to the NREC system. I was already a member of the HRCDC, which I still serve on, with Bridget McManus as chair. And of course, it's a great opportunity to work with people like Orla. So, so I think it's been a really fantastic experience and I really enjoy it. And I think we have the way of working and the camaraderie on the committee is really excellent. And so No, it's been a delightful experience, and you know, we're very, very well supported by a fantastic office. So Lucia and the team there, and Emily, you know, you couldn't ask for better. You know, it's really fantastic.
Well, thank you very, very much, and it's great. And thanks to all of you who are involved in this, by the way, for your time and commitment, because we really, really appreciate the time that this takes. And you know, this is what the whole system relies on: is people stepping forward to take these roles on. So thank you very much. Okay, let's talk a little bit about then some of the issues that are arising. And David, can I just go back to you? You just gave us a very, very thought-provoking keynote. You set the scene in terms of the horizon scanning that you're doing. Delving into that a little bit further, could you maybe talk about or even identify the one emerging area on your horizon for research ethics? And what do you think the associated challenges are with that area?
Thanks very much. Yep, happy to do that. I think, and it's nice that Barry is here on the panel. I think AI is a significant area of development, and I can just quote, I mentioned them in the talk, the Ada Lovelace Institute, which is the other institute within the Nuffield Foundation looking at AI ethics, and they have very specifically said that they think RECs are currently poorly equipped to evaluate, remember this is a comment about the UK, poorly evaluated to evaluate the wider impacts of AI research. And they drew attention to problems of the public good, but also the ethics of incidental findings, that is, findings that are thrown up in the course of, but not necessarily intended by any particular research. So I think that is a big area of development, and the development is very fast. And I think if you also relate that now to, I think, what some call the golden triangle, which is huge developments in cognitive psychology, at the same time as really interesting developments in neurology. You have this very, very potentially extraordinary combination of AI, big data, psychology, and neurology. So I'm sure you've all seen the publication of the findings by the Australian group who created, we have to be careful of terms, we can't call it a mini brain, but a surrogate brain. That is brain tissue, which was stimulated and showed itself capable of playing Pong, which is the tennis game. But why that was interesting is precisely because it showed evidence of responsiveness to an external environment. So we are at the beginning of the possibility of developing, let's call them artificial brains, substitute brains, surrogate brains. And if you link that to AI and psychology, there are enormous implications, and the ethical challenges here seem to me massive in terms of a proper understanding of what it means to be human, how we understand intelligence, whether or not we're on the edge of creating systems that might be thought of as sentient, capable of having various experiences. Those seem to me enormous challenges, and probably the major area which I see coming up over the next 5 to 10 years. And the thing to say here is, everybody knows that scientists say things like, and I've heard them say, oh, we won't be developing that for 10 years. And at the next meeting, they say, well, it's probably going to be around 5 years before we get close to that. And at the next meeting, a month later, they say, well, I think next year, a group in California is going to be publishing findings. So things happen very, very fast. And that's an area where I think we really need to be ready for the kind of ethical challenges that research presents.
Okay, Barry, would you agree with that, with your background?
Well, I think certainly AI gives the illusion of great progress and great speedy progress, but I'm not sure I would be as optimistic as Professor Archard. I think there are certainly major technical barriers to achieving some of the things that he's mentioned. But I absolutely agree that AI does raise lots of ethical issues, and one of the fundamental challenges with AI systems as they exist today is that they don't have what we call common sense. They don't have an understanding of the world. So, you know, they might give the impression that they understand the world, but of course they understand nothing of it at all. And so, you know, we need to be careful that we don't over rely on AI systems. And I think there are many kinds of ethical issues here that are raised. Professor Archer raised many of them. But also just, I think, relying on AI technology and giving AI technology too much respect, in a sense. It is a very, in some respects, AI is still a very primitive technology, and you know, we need to be concerned about that. I think what's very important is that the methodologies for using these kinds of technologies are well developed, and I think this is something that, you know, as an AI researcher, I am concerned about when I see generally systems that are deployed using AI, that there are often very obvious and surprising gaps in them, and of course we don't want this to be impacting on patients negatively and so on. But I would be quite cautious about AI. But one of the reasons I did step into the role of chair, although I did express an interest in it, is that I did feel that we do need more people with that background around the table. And I think we certainly need more AI skeptics around the table, not because, you know, we wish to be skeptical, but I think we need to really not drink from the Kool-Aid that you often hear in terms of how AI is hyped. So I think, you know, that's one of the things I tried to bring to bear, you know, on the few applications that we've had that contain AI, because even still, you know, it's not really widely used in many of the systems that we're deploying today. Thank you.
Yeah, balancing out the enthusiasm and the skepticism is often a challenge in this, for sure. I'm not sure the humans always have the monopoly on common sense either. But Mary, what do you think there about, you know, if you had to pick out an emerging area for health or for research ethics, what would you pick out?
I suppose what I'd really like to see is that infrastructure that we were able to quickly develop, being able to pivot rapidly in the event that there's a new, I suppose I'm an infectious disease specialist. So having the ability to really be agile in our ability to flex the whole system and be able to have it up and running really quickly. The other areas I think that are really important, there will be a national strategy which is rapidly under development in genetics and genomics. And I think we need to be part of all of that. I know the HSE are, you know, well underway and probably will be launching it in December. You know, I think that's because it's all new. David spoke about areas of it, and we should be thinking about that straight away.
Sure. Your view on this one? I'm not sure. Can you hear us, Alistair? You've got your muted at the moment. Sorry.
Sorry. No, you just broke up for a second. Great.
Right.
I was sure if you called on me.
That's okay.
Yes.
Around an emerging area that you think is important in ethics. So
the thing I actually might bring up would be platform trials, and this sort of follows on from what Mary was saying about being ready for the future. So the old way of doing business for trials was you do a trial, you get an answer, you do another trial to get the next answer. And platform trials are where you build that infrastructure that Mary alluded to in advance, the trial's running, but you are able to answer multiple questions at one time. So this came from the phase 2 world of cancer research. And during COVID, I was part of REMAP-CAP, which was a platform trial for COVID. And I was able to answer multiple questions at the same time. And so it's definitely a new way of doing business. Like David and Barry sort of said, a lot of grants were AI, and a lot of the platforms are the new black in a sense, and they're a more efficient way of doing business. But I'm obviously a convert because it gets answers at the bedside quickly. But I think the ethical challenges are a fewfold. So that patients understanding these new designs, that patients understanding they're actually going to be randomized into multiple different aspects of their care. And also for clinicians to understand that at the bedside, we actually will, with good reasons and good background, but we will give a number of decisions we would have made over to the trial to make. And that might be uncomfortable for some. And then again, the final aspect is for recs to understand these trials and understand the implications, and the stats aren't as simple as we once had that you could do on your calculator with a piece of paper. They require either trusting other people to make those calculations or trying to understand the framework. And in a sense, it's a bit like AI that way, that we are giving over some of that power to other people to make those decisions on our behalf. So I think it's very exciting. And maybe like AA, I think it offers real opportunities in Ireland for a new way of doing business to get answers. But again, we have to bring our clinicians, the public, and our recs and the researchers with us.
Do you think, Orla, from a patient's perspective, you know, that whole area of platform trials or just emerging ethical areas, what would your view be?
I suppose in terms really of the emerging ethical areas, I don't really know much or anything about platform trials, but in terms of the emerging ethical areas, and maybe it's a little reflective of my age, where you know, friends and family are switched from talking about children, we're all talking about our elderly parents and relatives. So I think that is very much to the forefront in terms of what we need to look to in the future, the aging of our population. And obviously that's an issue not only in Ireland, but also worldwide. And David has already mentioned that I think you said that you'd have a reporter will be publishing something on that this year. In Ireland, I know that the number of people who will be aged over 65 years is actually expected to double by the middle of this century, so by around 2050. So by that time, we'll have nearly 1.6 million people over the age of 65. While that increase in life expectancy, you know, it can be seen as one of the great achievements of modern medicine and research and indeed public health. I think it does also present challenges. So as people are living longer, they'll be living with more chronic diseases, multiple health and care needs. And there are implications for research ethics around all of that. So things like, you know, what research questions are being asked? Is the right type of research being done, and are the needs of older people and their carers being addressed, you know, as part of that research? Also, I suppose, you know, the difficult question of getting the balance right between the development of new drugs and new medical devices that will hopefully extend life, but that also remembering that has to be balanced against any assessment of the quality of life that we may want to have as we get older. So I think we're probably all in agreement we'd like to live longer, you know, or as long as possible, but probably only if we can be guaranteed a fairly good quality of life until the very end stages. And that in itself, I suppose, leads into, you know, probably more general things that we would, you know, we discuss more generally in ethics. So how you involve vulnerable groups, vulnerable patient groups like the elderly and, as I say, their carers in clinical trials, and particularly to involve them in, you know, in a collaborative way. You know, that classic kind of PPI, you know, statement that research should be done in partnership with these patients or participants rather than to these patients or participants.
And on that subject of the vulnerable groups, we'll come back to the aging in a minute, but on the subject of those vulnerable groups, Alistair, can I ask you just maybe to comment on that? I mean, you know, that very challenging area of making sure that research is inclusive, but when you're dealing with those vulnerable groups, you know, people maybe who can't make decisions, or you know, you'd be dealing with groups or with patients in ICU and so on. How do you approach that, and what are the issues there that we need to consider?
Yeah, so no, unfortunately, in my day job, many of our patients are unable to advocate for themselves because of the severity of their illness, and so for medical and treatment decisions, we have to talk to their next of kin, and in emergency situations, also, you know, when somebody rolls through the door of the emergency department severely unwell, we provide treatment, you know, in the public good to save their life. And so in a sense, for research, it follows the same sort of approach, that if a patient is able to give consent themselves, we ask. if a patient is unable to give consent. And again, this is different for different types of trials, but generally, if the time is available, we speak to their next of kin. And in some very specific circumstances, and actually this has been laid out clearly in the new clinical trial regulation, patients are able to be included in low-risk studies if they're not able to give consent or a family member is not immediately available. And then in both of those two other scenarios, we actually subsequently get either, it's actually called assent from the next of kin or consent from the patient if they recover. Now, it actually might be worth saying is actually to go to Orla's points about actually involving patients and the public in these decisions. So, like for instance, some of our work was pandemic research, some of our work is trauma research. And unfortunately, every one of us going to work this morning was a potential participant in one of our studies. If things have gone wrong, if you fell off your bike or the bus hit you or whatever. So what we have done as part of our group is actually to do focus groups and actually to do public surveys of patients in Ireland and abroad to see if these models of consent and assent are broadly acceptable, and they are, with over 85% of people saying, you know, they had no objections to these in low risk and in higher risk scenarios. And this is work we carried out prior to the COVID pandemic, where actually the public in Ireland and other places felt that there should be rules to allow emergency, trials to go ahead, that people thought these were important. And we aim to actually repeat this work after, in the next 6 months to see what COVID has brought to it. And in addition to Orla's point, we actually have panels of ex-patients and their relatives who give us input on our trials to help us develop patient-facing documents, but also to give us the sort of, as Barry and then Orla alluded, the common sense thumbs up that this is an appropriate question. Thank you.
Any of the other panel members want to comment on that, on the whole inclusion of vulnerable groups? And...
if I may come in, Mairéad, I think this is really, really important because a lot of the poor health outcomes are in marginalised groups. I mean, you see it either by the stigma of the disease, which is something like HIV or monkeypox, or, education level or cultural differences. And COVID again, highlighted that. So it's really important that a means of engaging with those who advocate and those on their behalves is done in a meaningful way. Because the person themselves may not be able to speak, but those that speak for them and support them absolutely need to be engaged. And it's everything from intellectual disability, the older patient and their carers that didn't really have a voice during the pandemic, marginalised ethnic groups within our country, which is so much more diverse than it was 20 years ago. So really to support what Orla said is the voice a representative voice of those is so important in designing and having input into trials.
David, you put your hands up there.
Yeah, I mean, just to, I think, emphasize what everybody has said. I mean, it's been a feature of a number of reports the council has had about involving so-called lacking in capacity or vulnerable groups, whether it be the very old, the young, or more generally vulnerable communities. And I think too often research ethics proof is almost seen as the last tick box exercise once the research has been designed, and then you're principally concerned with the downstream outcomes. Whereas it seems to me, if you think about it the other way around, about who's involved in the design and construction of research projects, and that's where it's really important that, say, children, the vulnerable, are involved. And that's been the recommendation of a number of our reports. And indeed, what a research ethics committee might ask of any proposal is, how far was the relevant group, the vulnerable group or the group lacking capacity, how far were they actually involved or encouraged to be involved in the design of this particular piece of research? And if not, why not? And just since I have a particular interest in the status of children, just to remind you that Article 12 of the UN Convention gives children a voice, a right to express their views on matters that affect them and to weight those views appropriately. And the next clause of Article 12 asks on all states parties to ensure that there are suitable institutional and other practical arrangements to allow minors or children to play their proper role. And I think we need to think about what that actually means in practical terms when we're doing research.
Orla, would you probably have an opinion on this one, I'd imagine, how we can actually involve participants and patients more in this whole process all the way through?
Yeah, I mean, it's gratifying to hear that everyone is very much seems to be certainly on the same page and stressing the importance. And I think that is recognition that I think that the role that PPI has is been recognised more and more, that PPI really will lead to better research, which can only, increase its value and ultimately its impact. I think David has mentioned a number of different roles where PPI can play its part. Obviously, I'm working on the NREC or a part of the NREC-MD, so and I'm only one of a number of patient representatives, both on NREC-MD and across the other two NRECs as well. So we have the role to keep it. I mean, when we look at everything, but we keep an eye out for particularly the patient information leaflet and other things in relation to that, all the way trying to ensure that there's a correct balance between the rights of participants and also the needs and responsibilities of the researchers. But I think, as David kind of alluded to there, there are lots of other roles where PPI, I think, could be strengthened in Ireland. Certainly, as I say, I'm only really new to this game, so I've been on the committee for the last 18 months. It's not terribly clear that there is a very strong role within the research system. So in terms of initiating research, there could be a role for either patient groups or charitable organisations to initiate research. We certainly, not that I'm aware of, have come across anything like that on NREC-MD. Equally, in terms of having a role in terms of writing actual research proposals, I've already kind of mentioned making sure that the right research questions are being asked. And again, I don't know if that is happening. It's not that apparent from anything that I have seen that's come across my desk. Equally, then, I suppose just the role in terms of reviewing the ethics or the material that might be put forward to an ethics committee. That's not a question that we ask. Certainly initially in any initial NREC application, sometimes we ask it as a looking for more information. In terms of applications and particularly in terms of patient information leaflets, we see some very good ones and we see some ones that need a bit of further work. And certainly, so I think within the research system, there could be more patient involvement throughout. They're obviously just some of the roles. Is obviously be a very important role of the actual participants, and that that goes without saying, I suppose. But there's lots of room, but I think importantly they are all interlinked. So if you get a PPI, some PPI involvement in helping to write the research proposals or review patient information leaflets, it should cut down on the time involved or on any delays in initiating the research or the actual clinical trial. And I suppose the one thing I would emphasize in terms of wider PPI involvement is that it shouldn't be a box ticking exercise. If you use, I think, PPI wisely and you evaluate that. I mean, as I think you said, Mairéad, at the beginning, I am an economist. That's my professional background. I've spent a lot of my professional career evaluating government programs and other stuff. And there are a lot of lessons to be gained from that. It doesn't have to be an onerous burden to just do a quick survey of what has worked and what hasn't, and there's ways of doing that. And I suppose in relation to, I think Ireland has probably come to the whole idea of PPI probably a little bit later than other countries. But the real benefit of that is that we can learn from mistakes that have been made elsewhere, and the development of best practice, obviously, elsewhere.
Absolutely, and we are trying to promote that, certainly in the HRB with the team here who do very good work in that space with the community. Of course, it's not just patients who need to kind of figure all this out, it's also the research community and the ethics committee members themselves. And I was just going to ask you this question, Barry, with all of the changes that have taken place, the regulations, the EU clinical trial regulations, so on, how do we actually prepare our ethics committees and train up our ethics committee members just to deal with all this kind of, I mean, really very rapidly emerging sort of challenges and a changing field and the law and all the rest of it? What do you think? How can we help people out?
Sure. Well, just for the audience or listening, the National Office do provide training for members of the committee. So there's before we stood up the committees, people were attending training. There was a training program offered, and so people were becoming familiar with the I suppose the conduct of ethics reviews, the relevant legislation, and so on. And of course, the committees are constituted so that you have a diversity of voices with a diversity of experiences as well. So there's great training and support provided, and I think also the committee has been learning from itself. So the expertise within the committee, it's quite a sizable committee. I believe all of the committees are quite sizable. So that's been excellent. And of course, when we identify that there are gaps in the expertise, then we have recruited additional members. So, for example, the NREC-MD is now taking care of not only the medical device regulation, but the IVDR. And so we augmented the expertise of the group with people who we specifically, with specific areas of expertise that we went up and targeted. So, but on a monthly basis, if not even more regularly, there are training programs, and we call them lunches and learns that people come along and participate in. So that's been very, very useful. I think there's a role that the NREC itself, that the National Office and the committees also have in educating the broader community. So we learn, and I think Orla made this point earlier. We've seen so many applications at this point that there are common kinds of pitfalls and I think we owe it to the community to come back with that advice and give suggestions in terms of the thinking and the common issues. And there are a handful of things that regularly come up, and of course there's the whole question of how do you nurture a kind of an ethical mindset in the system. I think I hope this doesn't sound weird. It's not intended to, but ethics committees do ethics reviews, but your ethical concerns should not end there. Just because an ethics committee said it's good to go, you have to exercise and practice that in an ethical way, and so on. And so we try to. I think we very much do regard one of the roles of the committee not only to educate ourselves to make sure that we're adequately trained, but also to give back to the community and create that sort of ethical mindset. And I think that could be a great sort of leadership role that the NREC system can provide. And I think, well, hopefully we're beginning to do that. I think in recent times we've been discussing, issuing advice and to the community, to the community, and of course that has been happening through the office itself. So hopefully that helps.
I know we're running out of time, but I do just want to ask David quickly. We have a whole issue here in Ireland around coming up with a harmonised approach to our ethics, because obviously there's lots of different layers, and as you mentioned in your presentation, lots of different actors involved. So how do we actually harmonise? Are there any lessons there, are kind of ethics decision making at all these different levels? Are there any lessons you could give us from the UK experience? I think you've been travelling this road a little longer than us.
No, I wish I could say that. I mean, I think that there is, it's just an impossibly difficult question here. I mean, what you want to do is have this right balance between, say, a principle of what's often called subsidiarity, that is devolving decision-making, ethical decision-making down to the lowest relevant level, which might be a local CC or REC. But you also want to balance that with consistency and harmonies across the sector. And I'm not sure I quite have got it yet as to what the right system is. I just think that the UK suffered very badly during COVID from this extraordinary diversity and plurality of advisory bodies, which I think was deeply confusing to those who were involved in making the really hard decisions at the front line. And it's bad news when you hear a clinician tell me we just ignored some of the advice. You know, we were just getting too much. And indeed, there was a kind of legal challenge being presented as to what on earth were we supposed to do. And if we're talking about clinicians rather than the research community, clinicians did feel that they were left stranded during COVID and not told what it was appropriate for them to do. And they feared the legal consequences of making very hard decisions and afterwards hearing, well, you didn't do the right thing. So
yeah, there's no doubt it was a very challenging time for everybody. Okay, unfortunately, we could talk about this all afternoon, but we have actually come to the end. But I just want to ask you, just very, just to finish up, really, just do a quick round robin here. Any final messages that you want to make? Alistair, I'll start with you, so we'll let you get back to the ward.
Yeah, no, look, I actually think the final message for me would actually be very positive. I think the office and the RECs, the NRECs, have done an amazing amount of work in the last 18 months, taking, you know, the volume of work from multiple regional ethics committees and bringing it under one roof. And then maybe just, so I think that was a huge amount of work well done. And I think the feedback we get ad hoc from the research community is that the system is actually pretty responsive, working well. And then to build on Barry's point, there's an opportunity now that tsunami of work has been dealt with, is to look at advocacy in the community and also to put the RECs on a established footing going forward. So I think it's positive.
Thanks, Alistair. Mary, final message?
Final message, I think that the research offices in the higher education institutes need a more harmonized approach that can be more rapid. The NRECs can't do everything, but if there's more collaboration, it allows interinstitutional work to be done, I think, better. And just to reiterate what Barry said, we certainly learned about the FAQs and put a lot of that up, because the issues, there was probably top 6 to 8 issues that came up all the time. So a lot of it is about feedback, education, and the ability for the research community to really work well with the NREC.
Thanks, Mary. Barry, do you agree?
Yeah, I agree with everything everybody has said. I think one thing I would encourage people to do is look at the NREC websites. So the minutes and the decisions and the deliberations are there. And so that material in and of itself is of educational value and gives an insight into the way we think. And I think it's been, for me, it's been a tremendous experience. And again, I just want to really thank the office for the fantastic support that they give, and also to acknowledge the fantastic work of the individual committee members. I can assure the community that the NRECs take their role extremely seriously. And as everybody knows who submitted an application, these are not insignificant piles of documentation, but I can tell you that every line is read and parsed carefully. And so I think it's just a tremendous service that the members of the committee give to the community as well. And I just want to acknowledge that. Thank you.
Great, thanks, Barry. And to Orla?
I suppose just to reiterate there what Barry has said, and speaking really just as a member of the NREC-MD, I think our committee anyway is working very well. Each application is rigorously reviewed, and I think where we've asked for more information, or in areas where we've suggested where changes should be made, in each case that has only served to strengthen the research proposal. So while, you know, applicants might be a little unhappy that they're, you know, that they have to do a little bit more work, I hope that they see the value that the NREC is contributing to the research environment in Ireland.
Thanks, Orla. And final words to you, David.
No, I just wanted to echo what everybody has said and congratulate you all on what seems to me a fantastic project and initiative, and I wish you well. And I do want to stress Barry's point. I think there's, in terms of education, there's clearly the training and education of those who make the recommendations or advise, and we're seeking to get an informed expertise, but you don't leave the community and public behind. And probably the single most important ethical step is to recognize that something is a moral problem. And my own experience from serving on committees is in university committees has been sometimes being rather surprised and horrified that people don't think there's an ethical problem in what they're doing. So that kind of education seems to me really, really important, and we don't want to leave the community behind when we do this work.
Thanks very much, and that's a good point to end on. So it just remains for me to say thanks to all of you, to all of the panelists for making the time to join us and to give us your insights, and indeed to everybody who submitted questions. We'll conclude on that note, and Emily, I'm going to hand back to you.
That's great. Thank you, Mairéad, and to all our panelists for that phenomenal discussion. It was really, really interesting.